At the Global Liver Institute, we believe it all starts with a patient. So what happens when a patient, a liver patient no less, one of the 500 million people living with conditions that often go undiagnosed, untreated, or misdiagnosed, mistreated, and stigmatized, brings the challenges of liver patients front and center? And what happens when a patient then leads a discussion with world experts in policy, research, clinical care, and wellness on ways to overcome these challenges? Let's find out today on GLI Live.
All right. Hello and welcome. I'm Jeff McIntyre, and you know me. I'm the Vice President of Liver Health Programs at the Global Liver Institute, and I'm really excited, especially today, to be able to host this episode of GLI Live. So in the United States, this is National Physical Fitness and Sports Month, and around the world, communities are gearing up for GLI's Global Fatty Liver Day, which is an awareness campaign that GLI leads to bring attention and awareness, expand screening and education, and really drive research forward around the most common liver disease in the world, fatty liver disease. And I could not be more excited to be joined by someone more equipped to talk about physical activity and exercise as medicine and the role of physical activity in the patient journey than Dr. Shelley Keating from the University of Queensland in Australia. Shelley, thank you so much for joining us. Welcome to GLI Live.
Thanks very much. It's really lovely to be here.
Yeah, excellent. So we reached out to you because last year you had participated and there was a new American College on Sports Medicine roundtable statement on physical activity and non-alcoholic fatty liver disease that was published. Can you talk a little bit about that? Why was that created? Why was the need? What came out of it?
Yeah, sure. So I guess in terms of why it was created, I think we all now know that the global prevalence of MAFLD or fatty liver disease is growing. So the stats are now, 1 in every 3 adults worldwide are living with fatty liver disease. So this is quite concerning. And the numbers are higher in people who are also living with obesity and type 2 diabetes. So it's a global concern and, certainly a growing condition. And we also now know that there's quite an abundance of evidence for the role of the benefit of physical activity and exercise in the management of MAFLD. The problem is that most people living with fatty liver disease are not sufficiently physically active. So they're not currently meeting the current recommended doses and guidelines that we sort of promote for health and well-being. So the ACSM roundtable statement was really driven by the desire to create evidence-based guidelines and recommendations for physical activity and exercise prescription in people living with fatty liver disease.
Now, this is interesting because you've used 2 words there in that description that really stand out to me of dosage and prescription. And so when we think about exercise or physical activity, we normally don't think about that. I think about going to the workout, about getting training in, about this sort of thing. Going off script a little bit here, can you talk about if there is any difference or what the difference is, especially for a person with fatty liver disease? We talk about movement, we talk about physical activity, we talk about exercise. Can exercise be medicine? And what's the importance of that to folks with fatty liver disease?
Yeah, those are great questions. And I guess to start with some general definitions. So we talk about physical activity as any bodily movement that, elevates your energy expenditure above that of rest. So that's anything from, walking slowly around the shops, doing some gardening. It could be fast-paced walking if you're running for the bus, but general physical activity. With respect to exercise, it's usually considered as planned and structured physical activity. Usually there's a goal to either be improving health or well-being or improving or maintaining performance and that type of thing. So there's a little bit of a difference in definitions there. So when we talk about exercise as medicine, we really view exercise as, I guess a polypill for the management of chronic diseases. So we know that exercise and regular exercise can benefit almost every cell, system, and organ in the human body. And I think the drive for research in the exercise medicine space is to really understand what we consider the dose of exercise. So how much to take, what dose, what intensity, what type, and how frequently do we need to take it to have whatever health benefit we're sort of seeking.
Yeah, interesting. So this is where dosage and prescription comes in then at that point. It's less, walk to the market or walk to the mailbox several times a day, and more specifically about looking at something that's geared towards fatty liver disease. So keeping, well, let me step back and talk about the call to action that you guys put out with the American College of Sports Medicine. In February, you issued this call to action for exercise as medicine for people with substance use disorder, which is really interesting. Could you see there being a similar sort of call to action for people with liver disease, and kind of frame that out for us? What would a call to action be for people with liver disease, and how might that impact patients?
Yeah, that's a great question. I mean, I think a call for action for exercise and fatty liver disease is certainly required. I think calls to action really elevate awareness of the condition and almost the urgency for management. And, one of the challenges working with fatty liver disease is that, as we know, it's relatively asymptomatic in the early stages, and often people aren't detected to have the condition until it's further progressed and the prognosis is poorer. And I think community level awareness of fatty liver disease is relatively low. So to elevate the awareness of the condition is sort of first and foremost for a call to action, but also the elevating the importance and urgency and prioritization of the role of exercise in the management of MAFLD, I think would be a core part of that call to action. It is, a mainstay of treatment alongside diet and now some pharmacotherapy, but I think that it's not always prioritized in the way it should be. So I think a call to action would hopefully increase, firstly, the awareness of the role and benefits of exercise in management. And a flow-on effect of that would be increasing access to sustainable options for people living with MASLD. So to help support patients living with the condition to be able to access exercise and sustain exercise lifelong.
Yeah, amen. I mean, I feel like I've just been in so many conversations with patients and frankly with hepatologists too, where they're so eager to reduce the resolution to one thing. It's, misguided information about calories in, calories out, or it's this pill will solve you, or, you have to get your 10,000 steps. And it feels like that incorporating it as a mainstay with these others is really so necessary. So kind of keeping with this theme of exercise as medicine, I want to talk about what you mentioned earlier about dosage, about exercise dose. There is so much content out there right now on physical activity, especially with, I can't say the rise of the internet anymore, but with all the influencers and people are looking to sell different things. We've seen everything from, cold immersion to high intensity, low aerobic, strength building. There's a ton of stuff that's out there. Is there any sort of consensus on what sort of physical activity is most helpful in the situations? I mean, is there a type of movement that is more effective at, say, reducing visceral fat or your risk of fatty liver compared to, say, other sort of activities?
Yeah, definitely. And so this has been a focus of our research and others worldwide, over the last handful of years, even the last 10 years. And I guess, firstly, the bottom line is anything's better than nothing. Right. So, any movement's better. And usually when it's, I get asked what's the best type of exercise, it's usually the one that you enjoy and will stick to long term, because like anything, consistency is the key. If you're not going to do it forever, right. It's important to choose one that you enjoy. But with that aside, I think the abundance of evidence is really geared toward the benefit of aerobic exercise. So, we've found a lot of benefit with doses of aerobic exercise of moderate intensity for, 150 to 300 minutes per week. And then I usually get asked, well, what's moderate intensity? And the way I like to usually describe it is, it's an intensity where, you are, huffing and puffing a little bit. You can maintain a conversation, but you can't sing. So if you can sing really easily when you're walking, you might want to go a little bit harder. We've also found benefit, with more vigorous intensity exercise at a lower time. So, 75 to 150 minutes of vigorous intensity aerobic exercise. So things like brisk walking, cycling, swimming, jogging or running, if you can do that, they're all considered aerobic exercises, which have been shown to be able to reduce liver fat and reduce visceral fat, which we know is really important for cardiometabolic health.
So like pharmaceutical resolutions or pharmaceutical things, I feel like physical activity can also be very individualized, or there's a necessity for it to be very individualized. And as you're going through this, we know that fatty liver disease, for instance, has so many co-occurring disorders with it, that there's such a high rate of cardiovascular disease, diabetes, which is obviously something, concerns about blood sugar. I think there's also a real mental health component to this as well. We've seen, certainly for people with diabetes, higher risk of depression and other mental disorders as well. Where does physical activity, or where does consideration for that fit into the picture as well? I mean, obviously somebody that's at risk for cardiovascular disease, you don't want to say go run a 10K. And that's also going to be incredibly demotivating for them and could make some other stuff work. Where does it fit in there?
Yeah, definitely. So I guess the first thing is, as you mentioned, individualized prescription is really important. So this is where working with, an appropriately qualified exercise specialist can be really beneficial, because, you can get assessed and evaluated to where your starting point is. And we certainly promote a stepped approach. So, small steps to sort of progressively build and to make sure you're doing exercise that are safe and, also effective. So the key is, finding out what someone's baseline is, what they're capable of, but also what their preferences and motivations are. So really sort of tailoring it to the individual in that regard. And I mean, I've spoken of aerobic exercise, and I mean, there is less evidence for resistance training in terms of lowering liver fat. There is some evidence for benefit. The results are a little bit mixed, but resistance training and muscle strength training is so important for improving body composition, muscle mass, bone health, and glycemic control. It has so many other benefits, including mental health. So we certainly promote muscle strengthening exercises, ideally on 2 days a week, as well as achieving the aerobic guidelines. So resistance training is super important as well.
Let me ask you something about that specifically. Back in the day when I was doing some work as a personal trainer, often people would come to me saying, I don't want to lift because I don't want to get too big. And often those concerns were, to me, somewhat unfounded, because they were just kind of avoiding the strain of picking up a heavy thing and not realizing kind of the benefit of resistance training, which doesn't necessarily have to be deadlifting or doing something, silly like that. With the rise of the anti-obesity medications, I know there has been some concern with things such as muscle loss. And I'm wondering if you would be willing to comment or what your opinion is, kind of around the rise of anti-obesity medications as it relates to physical activity. Let me stop with that, and then I'll have a follow-up as well.
Sure. Yeah. I mean, there's been huge discussions around that, and, people are losing significant levels of body weight, which is really favorable benefits on cardiometabolic health, but at the same time, large losses of muscle mass. And, in fatty liver, we know that there's a strong link between sarcopenia and the progression of MAFLD. So, muscle mass is such an important part of health, and particularly in those who are, aged and where sarcopenia and frailty become a big concern. So I think the bottom line is, I think all of these drugs are supposed to be prescribed in conjunction with diet and lifestyle and exercise advice. So it's sort of really promoted that they should be prescribed together. I don't know if it is, and there's been a lot of literature showing that those who have done exercise whilst taking the pharmacotherapies do maintain more lean mass than those who aren't, and in the long term, body composition outcomes can be even superior in those who are sustaining exercise than those who are just on the drugs alone. So I think that in terms of the actual evidence, the randomized controlled trials, they're still to come. But I think that, resistance training plays a huge role in maintaining, or at least minimizing, the losses of muscle mass that you see with the significant weight loss.
Yeah, I mean, I think that's my impression too, is that the evidence is still out a little bit, that we haven't really seen the long-term impact on that. And I think other folks, I think there's an assumption, perhaps there is an assumption that muscle loss equals the loss of muscle function. And that's not necessarily the case. I mean, is it? I mean, it seems like if one is still incorporating some resistance training while losing weight, that you still have muscle function. You still actually could have elevated muscle function if you're going from 0 to something, as you said earlier on. Is that a correct read, or are we off on that?
No, I definitely agree. And muscle function and strength and capacity is the bottom line of what we should really be caring about and targeting. So, certainly with losses of muscle mass, we might see some changes in strength and function, but we can certainly maintain a lot of that or even increase it. As you said, if the baseline is sort of nothing, we can increase that. So that should be really the focus of the exercise component of obesity management with the pharmacotherapy.
Are there any findings from your research that have kind of surprised you, that you've kind of come across and thought, oh, wow, that didn't quite go in the direction I thought it was going to go?
Yeah, there's probably a couple of surprising findings. The first one of my earlier studies was a randomized control trial where we were trying to ask the question of aerobic exercise dose, so which dose is most beneficial for improving liver fat and visceral adiposity. And we had sort of two doses, one which was higher intensity and lower volume, one which was higher volume and lower intensity. But we also had a group which was lower intensity and lower volume. And we sort of thought, oh, well, we'll see if, even these sort of low doses are effective. And we didn't really expect that group to lose significant liver fat, but we were quite surprised to see that they did. So it was the equivalent of 135 minutes of moderate intensity aerobic exercise. And this is, as you might know, below what we're currently promoting for physical activity. So we were quite surprised. And I guess it just sort of sings to the fact that, anything and, heading toward those guidelines can still be really beneficial. Sorry. Oh.
No, go ahead.
Yeah, I guess the other thing I was going to say, which was a finding that surprised me when I was doing some work in high-intensity interval training. So in this particular study, we got people who were living with steatohepatitis, and we got them in and did 12 weeks of high-intensity interval training. So the first thing that was quite surprising was many people believed that they weren't going to be able to do the higher intensities. And we found that they absolutely could. They could absolutely reach the heart rates and sustain those sort of high intensity intervals. They were screened and monitored and, supported in doing that. But one of the most surprising things was a couple of weeks into that training, the number of participants who reported feeling more energetic and having less body pain. So as an exercise physiologist, I get really excited when I see improvements in blood glucose control and blood pressure and reductions in liver fat. But to hear, the participants sort of really commenting on things like fatigue and energy really changed my mindset. And so certainly now I really promote patient important outcomes as a core of my research, because it's something I didn't consider as much before. And yeah, that was a really surprising but important learning for me.
I think, as the patients say, the patients would agree on that, that the benefits of physical activity and better nutrition are so often quantified in these almost clinical terms that really don't speak to the patient experience and speak to things such as motivation, as quality of life, of less depression, et cetera, et cetera. It's great to see that come about. When you say it was 130 minutes per week, 135 minutes per week, give or take a little bit, 135 minutes per week. When you said that, I'm thinking, these numbers often sound a little overwhelming. You mentioned 300 minutes a week, not 300 hours, 300 minutes a week earlier and whatnot. How do you break that down? Because as I see that, people think I've got to go out and do a thing for, an hour a day or something like that. But we're really talking about something that's closer to a long walk after lunch or dinner. Is that fair?
Yeah, definitely. So in the particular study, the participants were doing 3 45-minute sessions a week. So that was how they broke it up. But you could absolutely break it up into, 20 minutes on most days of the week sort of thing. You can, it could be a walk to work. It could be getting off the bus stop a couple of stops earlier. So trying to accumulate, 10, 20-minute blocks at a time. So that's, I guess, the nice thing about individualization is just trying to meet those targets, but you can certainly break it up in ways that fit within your schedule and your lifestyle.
Yeah, that's brilliant. I worked with a corporate wellness program once upon a time where what we landed on was for individuals to park a little further away for their job. And this was in a very suburban area where it didn't have very good infrastructure for walking and stuff, but just park in the furthest possible place away to walk a couple of extra blocks. And they found that their stress went down so much because they got the walking in, but also the cars weren't getting dinged up from fighting for parking spaces, and they were able to find parking easily every day. And it just became a much more enjoyable sort of experience for them as well. I want to talk a little bit about how diet and exercise has been, frankly, it's been the recommendation to reduce risk for so many chronic diseases. I mean, it's almost become kind of cliche in that way. And it's easy to say, but it's much harder to stick with. We find that with every New Year's resolutions. In your research, if you found that a particular approach or support research or support resource, if you will, has helped with longevity in any sort of dosage or physical activity prescription?
I actually think that's probably the biggest question we still have to answer today. So it's something that our team, and I know others, around the world, are trying to work on, is sustainability of exercise. So we find we have an amazing attendance and adherence to our exercise prescriptions in our research labs. We develop, it's a great social setting, and there's a lot of support, logistical support and that type of thing. But when we do ask participants to continue doing the exercise self-directed, so in their own way, in their own environments, the adherence certainly drops off. And that's, I think, found in large number of studies, across many different conditions. So it is really the number one question. And the last couple of years, I've been doing a lot of work engaging with our participants, with people with lived experience of fatty liver disease, to really ask that question of how can we break down the barriers and support people living with fatty liver disease to uptake and sustain exercise long term. And a few key things have come out. I mean, in terms of what does support, what's an enabler, accountability is a huge one. And whether this is accountability to a healthcare professional, an exercise physiologist, or even a family member or a social, a group member, a friend, accountability can really drive adherence. So having someone that you're accountable to. And so I guess there's some potential for digital therapies, mobile applications to maybe play a role in digital health and that type of thing, but it's still an emerging area in that regard.
Yeah, I mean, this really expands beyond individuals with chronic disease. I mean, I feel like that's the prescription, if you will, for supporting longevity and physical activity, period. I mean, this is why we have running groups. It's why, there's back when we had shopping malls, when shopping malls would open early for folks to do laps around the mall and safe spaces. This is, why we have dance communities. I mean, I really do feel like that's just a vital component, which also, again, plays to the mental aspect of it, mental health aspect of it as well. It's not just accountability, but it's also kind of building community in those instances as well. So we're beginning to see exercise specialists kind of integrated into fatty liver clinics here in the U.S. From your perspective as an exercise specialist, what would be the biggest challenge they face? Is it reimbursement? Is it kind of patient attitudes that they have to sign up for a 10K? Is it acceptance, of lifestyle research, by the medical community, of integrated lifestyle behavior into the medical community? What would you say are some of the biggest challenges for exercise specialists going into this space?
I'd say it's probably likely a combination of all of the above. I think there's probably many different challenges, but firstly, I'll say it's really exciting to see that exercise specialists are being integrated into clinical practice in the States. I think that's wonderful, because just the presence and access is a huge component of addressing barriers to accessing exercise support. So that's fantastic. I think, patient attitudes are, people thinking that exercise is hard. And if you haven't exercised for a long time, exercise can appear daunting. So I think with some, positive physical activity counselling, those perspectives can change pretty quickly. And, certainly promoting tailored, personalised, stepped approaches to exercise will be really important. I think one of the main challenges is probably, medical clinician buy-in. So, medical professionals really prioritizing and promoting exercise as, a core and central therapy. So we've done a lot of interviews with many different specialist nurses and specialist physicians. And, we do have a mixed response to, the questions around how important do you feel the role of exercise in managing the condition that you work within. And often it relates to how engaged in exercise the physicians are themselves, as to how much they really do promote and prioritize, and whether they we sort of have a theme of prescription versus promotion. So do they just say, you should be more active, or do they actually give some sort of prescription and referral to an exercise specialist? So I think, those models of care where referrals to the exercise specialist become more and more common will be really beneficial.
Oh, amen. It's such a pet peeve of mine to see, behavior needs to be modeled. in a positive way, to see, the wellness aspects representative within that given practice, within that office, within that individual as well. We've often seen such tremendous thing, and I think the field in which we work really has a lot to gain in that way. We have a long way to go. I would love to see some of these studies done within the medical community to see how the practitioners and clinicians are doing versus how the patients do in terms of this as well. I think it would be really elucidating. 2 last questions for you here then. I want to talk about kind of the larger aspect of physical activity. I think in the US, we often talk a lot about how we don't often have a great infrastructure for physical activity. There are exceptions to that certainly as well, and we're getting better in some places as well. Are there system changes that you feel like, bigger issues that need to be engaged in order to be able to promote physical activity?
Yes, certainly. I mean, the management of any chronic condition, but particularly fatty liver disease, does require systems level change. So there's still a lot of inequities in access to healthcare, and in particular exercise, care. There's a lot of inequities in environment, and we do know that environments with more green space usually have lower BMIs, and there's sort of a lot of relationship between environment and that type of thing. This feeds into, access to, poorer nutritional choices in schools and, in communities. So it is a systems level approach. It's certainly, above my capacity to sort of in the policy field. But I definitely think that, in terms of access to exercise professionals, and often we certainly in Australia, we have systems where people can be referred to an exercise physiologist under the Medicare scheme, but they require to be, have a chronic condition, or, in particular things like type 2 diabetes. But I think what message gets missed there is that physical activity should be considered the biological norm. It's not only as a medicine, we do promote it as a medicine, but that, it's actually a physical norm that we should all be achieving to live a healthy and well lifespan. So even if you don't have a chronic condition, we should be supported to be physically active. So I think, some messaging needs to change, and we all should be supported to have better access to services, affordable, gyms. I know that certainly in Australia, again, there's, a lot of amazing gym equipment being set up in parks, which are free to access. And there is those movements, but there certainly needs to be more.
So in conclusion here, I want to talk about, is there one societal belief or misconception that you think that you would change to make an impact on fatty liver disease and physical activity? What would that be?
Yeah, I think the biggest one for me is a societal perspective that, and it's sort of a narrative that exercise alone, so that is without diet, doesn't result in weight loss. So it's not really, that effective, if you will. But we do know, the benefits of exercise, the broad benefits of exercise occur irrespective of weight loss. So the benefits to liver fat reduction, visceral adiposity reduction, blood pressure improvement, glycemic improvement, mental health and well-being, they all do, occur in the absence of weight loss. So trying to shift the narrative that exercise is not a tool for, eliciting large weight loss, it's a tool for really gaining health and well-being. And we also know that cardiorespiratory fitness, so our aerobic fitness, is one of the most potent and independent predictors of all-cause and cardiovascular disease mortality. So that in itself, if we can just, forget about the scales and focus on improving our cardiorespiratory fitness, the health outcomes, for the population will be really huge. And the evidence supports that in people with fatty liver as well.
Yeah, amen. I feel like that aspect about its impact on all-cause mortality really is something that isn't mentioned enough to get us all out moving, modeling good behavior, and then also for those dealing with liver health issues of any sort to be able to improve and be able to hopefully prevent as well. All right, Dr. Shelley Keating from the University of Queensland of Australia, thank you so much. I know it's late on your side of the globe there. I really appreciate you sticking around and doing this session with us. You guys are doing amazing work at the American College of Sports Medicine and in Australia as well. This is certainly a global issue. Movement is life. And at the Global Liver Institute, we look forward to partnering with you and doing more great work together in the future. Thank you again, Dr. Keating.
Thank you. It's my pleasure.
Please be sure to like this video, subscribe, and share your thoughts and suggestions in the comments below. Join us weekly on Wednesdays at noon Eastern Time for more episodes of GLI Live. Check out our website, globalliver.org, and follow us on social media to learn more about the Global Liver Institute and stay up to date with the latest in liver health. Until next time, stay safe, stay well, and stay connected.